Chris Wallis. Thanks so much for joining us today on GU Oncology Now. I've got the pleasure today to speak with Dr. Jonathan Coleman from Memorial Sloan Kettering in New York about some of the work he's been doing, really advancing the care of patients with upper tract urothelial disease. Thanks so much for joining us today, Dr. Coleman.
Sure, Chris. Thanks for having me. Appreciate it.
So we were just talking before we went live that upper tract disease is a space that doesn't tend to get the same attention as many other urologic conditions. There's certainly other aspects of urologic oncology, but we've seen a lot of data and a lot of advancements in the last, 3 to 6 months even. And so you've been leading many of those, and I'm hoping today to talk to you a little bit about the neoadjuvant space for systemic therapy in surgical patients, and then a newer endeavor looking at ways perhaps to avoid surgery in many of these patients and spare their kidneys. So this is all in the context, of course, of the new AUA guidelines that you led, and I think have really given us a nice framework for those of us who treat upper tract disease to put all of our thinking and this sort of new advancements into a nice structured approach to diagnosis and management. So if we jump first to the question of neoadjuvant therapy, maybe you can tell us a little bit about the trial that you guys led and published in JCO earlier this year.
Yeah, thank you, Chris. So, yeah, I think upper tract disease, as you mentioned, has kind of been the stepchild disease for bladder cancer for a long time, and there's been a growing interest in the field because there's a lot of complexity in upper tract cancer. And it was interesting when we started to write the guidelines. We put together a group of people who are really dedicated and focused in this disease space, everywhere from a group of medical oncologists who treat with neoadjuvant and adjuvant chemotherapies, endourologists who treat with endourologic endoscopic therapies, surgical oncologists who are interested in treating patients with more advanced cancers, including consolidative surgery after chemotherapy and so forth. And the more we sort of dove into this set of guidelines, several things became very evident. One is that there's a lot more data out there than people expected. So there's been a lot of consortiums being put together that are collecting data on this very rare disease. So you have a very rare cancer in the upper tract that's somewhat genetically distinct, I would say, from lower tract disease. And we're starting to find that as we've been diving into the genetics of upper tract cancer. And there are also a lot of aspects of the disease that lend itself to either over-treatment with excessive surgery in some cases, but also the possibility for organ-sparing approaches. And so that's where I think people are trying to get into things a little bit more right now to isolate some of the nuances within this field. And then we learn just so much more about all the different treatment options that are available and how to standardize those options for the standard clinician. So starting with neoadjuvant chemotherapy, I think many of us realize that number one is that the field had been kind of stagnant for a while in terms of what we had for chemotherapy options, and really was cisplatin-based chemotherapy. And our trial actually started many years ago, back in about 2010 is when we first began this trial. And that was started here at MSK, and others had tried to do neoadjuvant trials in upper tract and had had difficulties. But with split dose gemcitabine and cisplatin, it's a much more tolerated regimen for patients. And I think that's what sort of opened the door to some degree to a more tolerable therapy for patients with upper tract cancers. And the rationale behind it really is that if you looked at what we get with surgery alone, so when a patient walks in the door with high-grade upper tract cancer, the answer to that patient is, if we take your kidney out right away, and I know you want to get your kidney out right away because this cancer is scaring you, we know from our past experience that your mortality rate due to your cancer over the next 5 years is about 50% with surgery alone, and even if we included the ability to use adjuvant chemotherapy. And the problem we run into is that even using adjuvant chemotherapy, while it can be helpful, and we know that now from the POUT trial, so there's very strong data from Alison Bertle's group that was done in Europe to show that adjuvant gemcitabine and cisplatin can be helpful. But the problem is that most patients after nephrectomy are not going to be able to receive cisplatin-based chemotherapy regimens. So that really was sort of the foundation and the for the need to provide these therapies up front whenever possible. So the neoadjuvant use of chemotherapy, I think, is now becoming standard of care at most centers of excellence around the country. And if you talk to teams at MD Anderson and Johns Hopkins and here and on West Coast at USC and others. I mean, people are really have embraced neoadjuvant chemotherapy for upper tract disease in the exact same way that we've embraced it for bladder cancer.